are going to be an outward sign of what's going on inside the body. So even though we can't see inside the body, it gives us a kind of a window in to see what's happening. Now, these vital signs, these observations that you're going to obtain, they're going to give you a whole lot of information. They're going to help with your patient assessment and your decision making. But you have to know what information you need, where to get it, how to get it, and what it means for each particular patient's problem. So your vital signs are going to be broken down kind of subjective and objective. Your subjective have a little bit of opinion in them. Pupil size, reactivity, whether they're sluggish or fast, skin's color, condition, temperature, things like that. And then your measurable, like your objectives, like your pulse rate, your blood pressure, or your respiratory rate, things like that. Now, all of this information you're going to get is great, but only if you kind of integrate it into an overall patient assessment. Just one single finding doesn't necessarily mean a whole lot out of context. It has to be in context with the rest of the presentation for the patient. So it's real important to know how you're going to do this. Now, when you get your vital signs, you're going to first get what's called a baseline vital sign. So in order to trend or see how your patient's changing, either improving or declining, you need to get a full set of vital signs as soon as you can, so that way you have a baseline, you have somewhere to start from. And then after you get your baseline vitals, you're going to repeat your vital signs. So you're going to repeat your critical patients, of course, every 5 minutes or sooner as needed, and non-critical at least every 15 minutes. So it just depends on the situation, but you will be repeating your vital signs. Now, the pulse is just a pressure wave that's felt in the artery, and this happens when the left ventricle is contracting or squeezing. So when this happens, there's this brief increase in blood pressure, which is going to expand the artery as the pressure wave moves through them. This is what we're actually palpating. This is that pulsation of each pressure wave. And we only palpate over firmer underlying tissues like bones or something like that, because that's where we're going to feel the pressure wave. Now, for a conscious patient, conscious adult, we're going to check a peripheral pulse. The most common peripheral pulse is going to be your radial pulse. For an unresponsive adult or child, we're going to use the carotid pulse in the neck. For infants 1 year or under, we're going to check the brachial pulse, whether they are conscious or unconscious, either way. When we're checking pulses, we are assessing for rate, rhythm, and quality. Okay? Normal is relative. So in order to really learn normal, you've got to touch a lot of people. You've got to check a lot of pulses. You've got to see what normal feels like. And then once you know what normal feels like, you'll be able to quickly identify not normal or abnormal. Now, when we check pulses, our normal pulse rate for adults is 60 to 100. Pediatrics varies based on their age. We are never going to use our thumb because we have a pulse in our own thumb. So you might feel your pulse instead of that patient's pulse. When you apply pressure with your fingers, if it's too light, you're probably not going to be able to feel the pulsations. If your pressure is too firm, you can occlude the artery and still not feel the pulsations. When we are assessing, we want to look at a couple of different aspects of it. The pulse should be regular, strong, and full. So if we have a regular, strong, and full pulse, then we're going to count for 30 seconds and multiply times 2. If we have an irregular, or abnormally fast, or abnormally slow pulse, then we're going to count for a full minute to obtain an accurate rate. Now, there's quite a few things that can cause, tachycardia, which is a fast heart rate, or bradycardia, which is a slow heart rate. For your fast heart rates, anxiety, pain, fear, blood loss, dehydration, fever, a lot of different things. Bradycardias, could be a cardiac conduction system problem, could be stimulation of the vagus nerve, could be hypertension. So there's several different things there. Some of them are life-threatening, some of them are not. So it's always important to just include this one component of your vital signs into your overall assessment. Now, as far as regular means that there's the same amount of time in between each heartbeat. Okay? A regular pulse doesn't mean that everything's okay with the patient, and an irregular pulse doesn't necessarily mean that there's a life-threatening problem. So once again, you've got to put it in context with everything else. When we're looking at volume and strength, your pulse volume is just a reflection of this arterial diameter, and strength is an indication of blood pressure. So normally we don't document the pulse being full because this is an expected finding. But if there is significant vasoconstriction, like in shock, it may feel kind of thready because of the decreased diameter of the arteries, and then you would document that. With blood pressure is simply the amount of force exerted against the walls of the arteries by the blood going through them. Okay, this is measured in millimeters of mercury, the mmHg, and a certain amount of pressure is needed for the blood to circulate from the heart throughout the miles of vessels throughout the body and then return back to the heart. And if this doesn't occur, then we're not delivering oxygen to the tissues and we're not picking up waste products and carrying them away from the tissues. So we have to have adequate blood pressure for adequate perfusion. Now, the blood pressure is going to depend on the volume of the blood available, how well the heart's working, and the capacity of that vascular system at any given time. So a couple of things here to remember: cardiac output, just how much blood leaves the ventricle every minute, and then stroke volume, which is how much blood is ejected from the left ventricle every contraction. Alright, stroke volume and heart rate are going to work together to make your cardiac output. Now, when we are measuring your blood pressure, you're going to get two numbers most of the time. And so what we're looking at is the first number that we typically talk about is going to be your higher pressure, and this is going to be systolic blood pressure. So this is ventricular contraction. The lower number is going to be ventricular relaxation, and this is the diastolic blood pressure. Usually you will see this written as one number over another number, or one number slash another number. So like 110 over 70. Now, when we measure the systolic and diastolic blood pressure, it's possible to calculate two other measurements as well that can be kind of helpful. So pulse pressure is one, and this is what's going to be the difference between systolic and diastolic. So systolic minus your diastolic gives you your pulse pressure. And pulse pressures can get narrower or wider over multiple reasons for a lot of different reasons. Okay, but that's important to note if they are. You also can calculate your mean arterial pressure. So your average, this is your average of pressure in the arterial system. This is important because we want a map of at least 60 millimeters of mercury to adequately perfuse the brain and the kidneys. Okay, so the most common way to estimate this or to calculate this is to take 1/3 of the pulse pressure and add it to the diastolic. So if you have somebody with a blood pressure of 110 over 80, right, the pulse pressure is 30. 110 minus 80 gives you 30. 1/3 of 30 is 10. Okay, now add that to the diastolic of 80, so 80 plus 10, and you get a mean arterial pressure of 90, which is sufficient to perfuse to the brain and the kidney. When you are actually assessing for blood pressures, they have a mark on the blood pressure cuff that is supposed to be lined up with the brachial artery in the antecubital fossa. So make sure that it's positioned properly, so this way the bladder occludes the blood flow through this vein. Okay, you can do this to ensure that it is occluded by auscultation, listening during inflation, or by palpating over the brachial artery. You can hear the first pulsations of the blood that are going to be higher than the pressure in the cuff with a stethoscope. These are called your Korsakoff sounds. All right, and this is what we're using to determine your systolic and your diastolic blood pressure. So at first, these sounds are going to be sharp, tapping sounds, and then they're going to get kind of muffled and then go away. Okay? When we are palpating the blood pressure, the pulse in the radial artery is felt as the blood is deflated. The first time you hear the pulsation is going to be your systolic, and then you obviously are not going to be able to get your diastolic because you're going to continue to feel a pulse. When you are inflating your cuff, super important that you do not overinflate it. If you overinflate it, it can artificially increase the blood pressure and give you a false reading. It's uncomfortable for the patient. Underinflating the cuff can result in missing the first Korsakoff sound, so you won't get an accurate reading there. So to make sure that you're getting the proper inflation point, palpate the radial artery as you inflate the cuff. When the radial pulse disappears, inflate the cuff only about 20 millimeters of mercury more. A special note, when you have a patient who has a hemodialysis access point, shunt, fistula, something like that, you do not take a blood pressure in that arm. If they've had a mastectomy that involved removal of lymph nodes, then you don't take a blood pressure in that arm. And what happens is fluid gets forced out of the capillaries by the pressure of the inflated blood pressure cuff, but without the lymphatic system, it can't return back into circulation like it normally would, which can result in some residual edema in that arm. And most of these patients who have these problems will know and will not let you take a blood pressure measurement on that affected side. If it is a dialysis patient that has both fistulas or shunts in both arms, or if they've had a double mastectomy, ask them where their doctor normally takes their blood pressure, and then that's what I will use. Now, as far as children go, typically we are not going to routinely get blood pressures on anybody under the age of 3. Okay, instead we're going to look at capillary refill time and things like that. But for those pediatrics above the age of 3, a good rule of thumb for a minimum blood pressure is their age in years times 2 plus 70. So this would be 4, so say they're 4 years old. So 4 times 2 is 8 plus 70, so 78. So that would be your minimal acceptable blood pressure. Now your normal blood pressure, I'm doing the quotation marks there, your normal pediatric blood pressure, age in years times 2 plus 80. So the same in 4-year-old, 4 times 2 is 8 plus 80 is 88. So that would be our normal number there that we would want to see. Now with your orthostatics, they're useful, but they take time to do it. Right, so you've got to weigh the benefits, is this information that we might gain worth the time needed to perform the procedure properly? Right, so what we're looking for here is called orthostatic hypotension or postural hypertension. And what this is when it occurs when they change from a prone to a standing position. Right, so average 500 milliliters of blood or so can move into the lower extremities when they move positions because of gravity. And then the muscle contractions aren't strong enough to get the blood back immediately, so it takes a minute or two. So when something interferes with this ability to compensate and return circulation back to normal, that blood pressure will stay low instead of returning back to normal. And this can result in lightheadedness or syncope. All right, a lot of different things that can cause this too. So this can be useful when you think that there may be a medical cause, dehydration or blood loss, but you don't have any clear evidence. If there's already clear evidence of those conditions, there's not really needed to do orthostatics because you already know what it is. Okay, you might make them faint and then cause injury to them. So in order to do it properly, you're going to have them lie down supine for at least 3 minutes first. Then you're going to take the blood pressure and the heart rate, and you're going to leave that cuff in place and have the patient stand for 3 minutes. Then you're going to retake the blood pressure and the heart rate. If they have, after 3 minutes, they have a drop in systolic blood pressure of 20 millimeters of mercury or more, or an increase in heart rate of 20 beats per more per minute, 3 minutes after they have assumed an upright position, then they have a positive tilt test or a positive orthostatic. Now, when we're looking at respirations, respirations is a really complex thing, and it involves ventilations, external respiration, internal respiration, gas exchange, all over the place, right? So ventilations is simply the air moving in and out. So when we consider that when we say we're assessing the respiratory rate, we're really just assessing the ventilatory rate. So it's really important to look at several different aspects there to make sure you're getting an adequate picture of what's happening. Okay, of course we know adequate ventilation requires the brainstem, a functioning nerve pathway, integrity of the chest wall and diaphragm, and all that stuff, right? If you're a little bit lost on that, make sure you go back and review over the airway and the respiratory components. Okay, so when we are assessing the ventilatory rate, even though we call it respiratory rate, we're measuring the ventilatory rate. We're looking at rate, depth, effort, and regularity. Okay, an adult normal rate is going to be between 12 and 20 breaths per minute. Now keep in mind, this is normal. If you're asleep, that rate may be a little slower. If you're running around the building because a bear's chasing you, that rate's going to be a little bit higher. So once again, these vital signs are to be taken in context with the current assessment situation. When we are looking at this rate, part of the depth that we're assessing is going to be that tidal volume. And tidal volume is really important. The average adult has a tidal volume of 5 to 10 milliliters per kilogram of body weight, which is usually about 500 milliliters. Now, we can't actually measure tidal volume in the pre-hospital setting, but we can look at what their minute volume should be versus what it appears to be. Okay, so let's say 500 milliliters goes in. 350 that's going to reach the alveoli and the bronchioles, but 150 remain up in the upper airway and bronchi, which gas exchange doesn't happen. So that's called dead space. Alright, so if the tidal volume goes down, let's say now they had 350 milliliters of air for gas exchange. So let's say their tidal volume, they have shallow respirations, that depth is not there, and now they're only breathing in 300 milliliters. So 300 milliliters comes in, the dead space stays the same, so still 150. So now you're only left with 150 milliliters of volume for gas exchange. It's half. It's a lot less, right? Because that dead space constant there. Now, when we are evaluating our ventilations, we're going to start in the primary assessment, okay? We're noting if they have accessory muscle use, tripoding, leaning forward on their arms, anything like that. Any abnormal noises or signs of respiratory distress, cyanosis, altered mental status, anything that might give us a clue here, all right? A patient's awareness, if you're assessing their ventilations, they can alter it to the better or to the worse. So they recommend, and most people will do it, when you're checking a pulse manually, which you should do on every patient at least once, then after you've counted out your 30 seconds, go ahead and keep counting, but look at their chest and check their respiratory rate with kind of, without them noticing what you're doing there. Okay, look at their chest rise and fall. Now, when we are assessing breath sounds, this also should be included during your assessment here. If you have noted any abnormal things in the primary, you address those. But these may be later on, or you may address them as soon as you notice them, like during your secondary assessment, okay? When you take breath sounds, you're going to put your stethoscope directly on the chest. You do not listen through clothing if at all possible, because what happens is you get a little bit of friction rubbing there and it can alter the sounds, it can muffle the sounds, it can make things just sound totally different. So you always want to make sure that you're putting it directly on the chest whenever feasible. Alright, we're going to listen to normal air movement in all fields of the lungs and compare both sides. So if we listen to the top upper right, then we're going to move over and we're going to listen to the top upper left, and so on all the way around. Now you may have to alternate or maybe modify slightly where you place your stethoscope. Say if the patient has large breast or something's in the way, you may have to listen more on the sides. You may get better usually get better lower lung sounds on the back versus the front, just because of where that chest tissue is. Or maybe sometimes on the sides there, under the arms. Any abnormal breath sound, regardless of which one it is, any abnormal breath sound is going to be called adventitious breath sounds. So that's no bueno. So we're going to go through a couple of upper airway breath sounds. All right, our snoring is partial occlusion of the upper airway by the tongue. Ooh. Gurgling is indication of fluid in the upper airway, and think like if you ever gargled with like a saline rinse or something in your mouth, kind of sounds like that, like a gurgly noise in there. Stridor is that high pitch that indicates an obstruction of the trachea or the larynx. Obviously, if you hear that, we know that's not good. We recognize that sounds terrible. Right, crackles or rails will be fluid in the smaller bronchioles and alveoli. To me, it kind of sounds almost like an old record player static. That's what it kind of reminds me of there. Now, rhonchi is fluid in the larger airways, and this kind of reminds me of almost like milk bubbles or something. You ever like took a straw and blow bubbles in your milk when you were a kid? And if you didn't, you're missing out, and you need to get a glass of milk and a straw and do what I'm talking about. You'll see, you'll enjoy it. You can thank me later. It sounds thicker. It sounds more coarse. Those are going to be your larger airways. This is more like a pneumonia, bronchitis type situation, and can be caused by mucus or other things like that. Now, wheezing, we've got inspiratory or expiratory wheezing, and this usually is going to be in patients with asthma or COPD. To me, it kind of sounds like a baby cat. Now, one thing to keep in mind with your wheezing, just because you don't hear wheezing doesn't mean that they're not having a problem breathing, because if it tightens down enough, you may not hear air moving at all. So that's a very important thing to remember with your wheezing. Now, for your temperature, typically, we're going to take our hand and feel with the back of our hand and get a general idea of body temperature, whether it's high or low or something like that. So normal body temperature taken orally is 37 degrees Celsius or 98.6 degrees Fahrenheit. Now, it can fluctuate over the course of a day. It can go, maybe as low as 96.4 or as high as 99.1. Temperatures that are taken rectally are usually about a degree Fahrenheit higher than your oral temperatures, and your tympanic temperatures may be almost 0.8 degrees Celsius or 1.4 degrees Fahrenheit higher than your oral temperatures. Okay. If you must take an axillary or under the arm temperature, keep in mind that it's less accurate and it could be a degree lower than oral temperature. Now, fever or pyrexia is just an elevation of body temperature above normal, and this could be caused by infection, it could be a blood transfusion reaction, medication reactions, hypothyroidism, but usually we're going to see it as an infection of some sort. And of course, hypothermia is going to be a lower than normal temperature. Now, as far as temperatures where we need to be concerned, a fever is not considered significant until it's 100.4 or higher. Okay, so we're not usually going to treat low-grade fevers unless they're uncomfortable. Now, another term that you need to be familiar with is hyperpyrexia, and this is an extreme elevation in body temperature, and this is going to be like 106 degrees or higher, and this is going to be where you start having brain damage and things like that. Now, not everywhere keeps thermometers. I've worked at several different agencies over time, and only one of them with any routine had a thermometer in the back of the truck for us. Keep in mind that usually the ones that they do have are going to be the electronic scans that scans the temporal artery at the forehead to measure temperature, and studies are kind of mixed on how accurate these are. Alright, and these consumer grade ones are probably going to be less accurate than any professional devices because you can't get these over the counter at Walmart or something. So make sure that if you're using a temporal scanner, it's recommended that you scan the forehead and behind the ear to get kind of a range there of where you're looking at. Assessing the skin can tell us a lot of information about their overall condition. So we're looking for color, moisture, temperature, turgor, mobility, how easily it can move and how well it rebounds from what it is. So we are going to look for some things in certain areas. Specifically, let's say if a patient's skin color is darker, it may be more difficult to see overall changes, so we're going to look somewhere like in the mucous membranes, like in the inside of the mouth or the lower eyelid, and that's the same pinkish color on pretty much everybody. Alright, it's also a good place to check pallor and sometimes even jaundice a little bit. Alright, if they're red, it could be generalized, like hot environment, fever, something like that, or it could be localized to an area of inflammation. So that also can give us a little clue as to what's going on here. We want to check for excessive dryness or excessive sweating, and once again, there's several different things that can cause either one. To check for mobility and turgor, we're going to gently pinch and lift up a fold on the skin, such as on the back of the hand or something like that. Then we're going to release it. Mobility is how easy that fold of skin can be lifted. All right, and then and where you would see this being decreased is something like edema or something like that. All right, and turgor is the speed in which it goes back to normal. Normal skin that's well hydrated should go back almost instantaneously. So if it doesn't, if it stays up, that's called tinting. That's not good. Now, here's some charts that have a couple of different potential significance. So like your pink skin, normal skin color, pale may indicate peripheral blood vessel constriction, could be shock or fright. Cyanosis could be due to hypoxia. Flushed could be fever, exertion, hyperthermia, excitement, or embarrassment. Jaundice usually is indicative of liver disease. Right? Mottled could be exposure to cold or shock, and that's usually a more later shock sign. Right? If it's cold, it could be due to hypothermia, it could be due to poor perfusion. If it's cool, it could be shock, could be anxiety. If it's warm, that's normal. If it's hot, it could be fever or hyperthermia. Excessive dryness could be dehydration. Moistness or wetness could be fever, shock, fear, anxiety. All right, poor mobility usually is going to be edema, and poor turgor is usually going to be dehydration. Pupils is the opening in that ring-shaped muscle of the eye called the iris, and the size of that pupil is controlled by the oculomotor nerve, which is cranial nerve 3. All right. It's controlled by your sympathetic nerve fibers, and the parasympathetic stimulation causes it to constrict, and sympathetic stimulation causes it to dilate. And so pupil size is determined by a balance of the sympathetic and parasympathetic input from a bunch of different stimulus. So under normal circumstances, they're slightly larger, more dilated in dim light, and slightly smaller and more constricted in bright light. when you shine a light in the eyes, the pupils should constrict. And they react consensually, which means if you shine a light into one eye, both pupils should do the same thing. They should both constrict the same way. They are normally round and equal in size, and sizes range from about 2 millimeters up to about 8 millimeters in diameter. A lot of different things, fear, dim lighting, drugs, things like that can stimulate that sympathetic nervous system, can cause pupillary dilation. Incomplete relaxation of the iris is going to occur in cerebral hypoxia and death. So this is what we call like the fixed and dilated. Drugs that block the parasympathetic nervous system can actually prevent the pupils from constricting and allowing the sympathetic nervous system to control the pupil size. So if you've ever been to the eye doctor and they put those drops in your eyes to dilate them, that's actually atropine, and what that is actually blocking the parasympathetic system, so it makes them really nice and open so the eye doctor can see in the retina in the back of the eye. It's pretty cool. Now, anisocoria, which just means slightly unequal pupils, is normal in a fair amount of people, but it should be about equal in size. If you have anisocoria of 2 millimeters or greater, you should probably be concerned. And if you're not sure for 100% if this is normal for them or not, consider it to be abnormal until proven otherwise. Now, in order to properly assess the pupils, we need to dim any bright ambient light. If you can't do that, like, you're out in the sun, you can't really dim down the sun, put your hand over their eyes. Just kind of shade their eyes a little bit for a few moments before you shine a light so their eyes can get normal. You get a little bit better base reading on their pupillary response. And then you're going to keep that hand over a little bit, briefly shine your pen light into one eye. And then you're going to come over and go to the other one. And they should both constrict and move together, and they should return to their original size when that light's gone. Okay? It should occur quickly. So this is a brisk response. If you have normal pupil reaction, this is usually going to be documented as pupils equal and reactive to light. So pearl is usually how you'll see that documented there. Now, pulse oximetry is a pretty good tool to have, but it's not infallible, okay? What it's doing is it's using light to measure how saturated the hemoglobin on the red blood cells are. Now, we're using it to measure oxygen, how much oxygen is saturated on the hemoglobin, but other things like hemoglobin too, like carbon monoxide, so it can't tell what's bound to the hemoglobin, just that something is. So it's important to keep context with your patient, right? Because they're in a structure fire and they've got 100% oxygenation, but they're showing signs of poor perfusion. Well, their hemoglobin may be 100% saturated with carbon monoxide. So, anyway, what we're doing here is the light source of this pulsimeter is placed on one side of the capillary bed, and sensors are placed on the other, whether it's a finger, an earlobe, a toe, whatever. And it's going to give saturation percentage. Okay? Normal pulse oximetry readings should be between 95 and 99% at your lower geographical elevations. I'm not sure exactly what cutoff they consider lower, but like if you're from Colorado or something, then they say readings of 91 to 94% are okay. Because, you're a little bit higher, the air's a little thinner. All right. Readings 91 to 94% indicate mild hypoxia, 86 to 90% indicate moderate hypoxia, and 85% or less indicate severe hypoxia. Yes, the way it works, the lower the number, the worse off it is, right? So our goal is to maintain an SpO2 of 95% or higher, and if need be, giving them some oxygenation or assisting with ventilations. Now, some other things to keep in mind: pulse oximetry is not infallible, so it can be affected by what's bound to the hemoglobin, but also high-intensity ambient lighting, poor perfusion in the capillary beds, and anything that interferes with the light source being passed through the tissues like scar tissue or something else like that. So, temperature also. So keep in mind that this is a tool, it's not the end-all be-all. Now, your end-tidal carbon dioxide monitoring is awesome. Everybody should do it for a lot more patients than we do. People tend to go back and just use this on intubated patients, but it's got a really great place for our non-intubated patients as well, and gives us a really good look at their overall blood chemistry, as far as oxygenation goes, or carbon dioxide amounts, their acidosis, alkalosis. Really cool stuff here. Your capnography is just the waveform itself. Okay, so this is going to be a waveform and carbon dioxide measurement, so the capnogram. And then capnometry is going to be that number, the actual number that you get at the end of the capnogram. Right, so our normal range here is going to be 35 to 45 millimeters of mercury, and this is going to directly correlate to the partial pressure of CO2 in the arterial blood. So this is a great way to see where we're sitting at with these patients. For more information, I do have another presentation just going over reading of the capnography. Now, another monitoring tool we'll use, blood glucose, right? Who all gets a blood glucose check? If you answer everybody, that's not wrong, but at minimum, everybody who has any signs of hypoglycemia, hyperglycemia, or altermental status needs to have a blood sugar check, even in trauma, because that whole secondary problems that you get with a lot of your trauma and brain injuries, we gotta have two things to make a body work, glucose and oxygen. So super important that we have enough glucose there. Our normal blood glucose levels, now to be fair, the different books will tell you slightly different things, but typically you're going to be 60 to 70 up to about 100, 110 will be considered normal range. Now once again, I've checked blood sugars on people who were conscious walking around doing their jobs and they were like 40, and I was like, oh, that's a little low, you might want to eat something, and that was their normal. And I've checked people, some people have residual blood pressures, have residual blood glucose levels 150, 160, 170. I've even seen some that stay in the 200s, and I was like, that's a little high. They're like, oh, that's good for me. So once again, in context with the whole patient's presentation and assessment here, okay? We've got to check blood glucose though, because without blood glucose, our brain won't function and then our bodies won't function. Now, cardiac monitoring is assessed by obtaining an EKG or ECG, an electrocardiogram. Some advanced EMTs can assist in connecting these patients, and in some places may be able to recognize a few dysrhythmias, but for the most part, you're going to be obtaining and transmitting with the cardiac monitor at the advanced level. So what this does is it uses electrodes that are placed on the skin to detect a minute amount of electricity that's coming through the cardiac impulses. Okay, and it's going to be displayed on a real time on a screen, and what we're looking at usually is lead 2. And this is going to look at the electrical activity from a positive electrode on the right shoulder and a negative electrode placed on the skin below the apex of the heart, usually in the left lower chest. All right, and this lets us see a couple of different things, rate, rhythm, things like that. All right, and there are some waveforms of the ECG that basically tell you how much and what direction electricity is being conducted through the heart, which gives you some more information about it. But that's more going into it on the paramedic level from there.